the hospital, they're not going to get paid.
Well, they don't care. They're going to charge you anyway, you know?
Hi, everybody. It's about 6:03 right now. We're going to go ahead and get started. We have a presentation today, and so we're going to amend the agenda a little bit to accommodate the presentation before we get to all of our voting and roll call and things like that, okay? So I'm going to go ahead and get started with the welcome statement. Welcome to the HIV Health Services Planning Council meeting of the Middlesex-Somerset-Hunterdon Transitional Grant Area. We usually meet at 6 p.m. on the first Tuesday of each month. The meeting is open to all who wish to attend. We request that everyone adhere to the ground rules on the back of the agenda. Thank you. The Sunshine Law, the notice of this meeting pursuant to the Open Public Meetings Act of New Jersey, SA 10-4-10, and Bill A3850 has been complied with and shall be entered in the minutes of this meeting. And I actually forgot to mention to our lovely minutes taker that we started the meeting at 6:03. Okay, so for teleconferencing etiquette, for those of you on Zoom, feel free to raise your hand or unmute so you can say what you need to say. If you're on the phone, please use *6 to mute and unmute, and then *9 to raise your hand. All right, so we're going to do a quick introduction today with a quick icebreaker, okay? So I guess I'll go first. Our icebreaker is your favorite summertime activity. Okay, and my name is Minu Christian. I am the chair of the Planning Council. I'm also the program coordinator at Eric B. Chandler Health Center. Oh, my favorite summer activity is, I think, going to parks, like walks in the parks. All right, so I'm going to go right down my list. I have Terry Fox as my first person.
Hi, everyone. My name is Terry Fox. I am the quality manager / program support / care technical assistance staff person. And my new favorite summer activity is bird watching.
Thank you, Terry. Kathleen.
Exercising.
Come on. Oh, there it goes. I couldn't get it to unmute. Kathleen Donahue, HIV positive. I'm on the Planning Council and on the Mentor Outreach Committee, and I attend the Brian White Part D meetings. And favorite summertime activity is, I don't know. Anything that will keep me cool. I try to be cool, so.
Totally understandable.
Car rides. Just
Thank
in
you.
the car with the air on. Okay.
B.
Hi, I'm B. Franklin. I'm substance abuse counselor at New Brunswick Counseling Center. And my favorite activity during the summer is going to walk in the parks, but it has to be very early or very late in the day because it gets way too hot. And in the middle, I like gardening.
I agree with you, B. Thank you. Karen.
Hi, Karen Burke, HMH, case manager, nurse. I'm just happy that there's sun outside and my anemic bones don't hurt all day. That's the best part of summer.
Thank you, Karen. Steve?
I hear you, Karen. Hi, my name is Steve Pitts. I'm a medical case manager with the Visiting Nurse Association Health Group, and I enjoy playing golf in the summer.
I think I knew that answer. Thank you, Steve. Anne?
I'm Ann Bagchi. I'm a professor at Rutgers. As Roseanne noted, used to be with the HPG some time back. My favorite summer activity when I can do it is traveling. This year I'm going to Ireland, so happy about that.
That sounds fun. Thank you. Dennis?
Hey everybody, I'm Dennis, program coordinator for the VNA. and personally living with HIV, I would have to like say what I always say. It has to do with food. I love a good barbecue. I like the
Yeah.
beach, but not when it's too hot. But that I look forward to the summer foods, like the stuff you get on the boardwalk or at fairs and festivals.
That sounds delicious. Like a good hamburger sounds really good right now.
I know, now I'm
Jen,
hungry.
I'm sorry, somebody said something?
I said, now I'm hungry.
Oh, Jen,
Hi, everyone. Jen Pipiak. I am Planning Council support staff. And my favorite summer activity is anything pool related because I hate the summer. Just like it cool.
thank you, Jen. Roseanne?
Everybody, excuse me, I'm Roseanne Marone. I'm the program coordinator for the Robert Wood Johnson AIDS program in New Brunswick. And I guess my favorite thing with the summer is walking along the beach and going into the ocean. Thank you.
That sounds great. Jose?
Hello, everyone. I'm Jose Roman. I'm back at Central Jersey Legal Services. So I'm a senior staff attorney with Central Jersey Legal Services, providing free legal services in Mercer, Middlesex, and Union counties. I'm also a bird nerd, so I like birding. You can just, so you can watch birds all year long. So I have at least five bird feeders. They're really cool. In the summer, I love using my hummingbird feeder because they start coming out around this time of year. So if they're really easy to use, you just need water and sugar to fill it up. So I recommend everybody buy a hummingbird feeder.
Welcome back. Ed, you're up next.
Hi, everyone. Edward Kelly, person living with HIV. I also work at Hackensack Meridian Health in Perth Amboy as a Ryan Wade funded medical case manager. And I'm with you, Roseanne. Beach walks, ocean, that's my thing for the summer. Makes me happy, makes me grounded and peaceful. Water has a very curative effect for me.
Thank you, Ed. Kelly?
Hello, I'm Kelly Fowler, the Regional Service Manager at Hydrogen. And my favorite thing to do in the summertime is riding my motorcycle. I actually look forward to it. I can't wait.
Thank you, Kelly. Lucy?
Hi, Lucy Counts, Middlesex County Office of Human Services. I enjoy anything that gets me outside because I don't like being inside during the summer.
Thank you, Lucy. Tanya?
Hi, I'm Tanya Williams. I'm the co-chair for the Middlesex-Somerset TGA. And my favorite thing is traveling. I travel all the time. Doesn't matter what kind of weather, just traveling.
Thank you, Tanya. Lara?
Hi, everybody. I'm Lara Dykstra. I'm with the New Jersey Department of Health, DHSTS, Division of HIV, STD, and TB Services, committee member. I am going to second everything that everybody has already said. There wasn't a thing that I didn't like, but to add to it, or I wouldn't do, I love, I know I've said it before, like the long days. So all of the extra sunshine. So anything kind of in that later half, because I too am not a super fan of all the heat. So anytime there's like an outdoor concert and when you can go from it being like light and then it goes to dark, like that's one of my favorite things about summer.
Thank you, Lara. Kareem?
Hi, everyone. Kareem Darwish, medical case manager for the VNA. I also like kind of everything. I like going to the beach, and I also like going to like outdoor shows and concerts during the summer.
Thank you, Kareem. John?
Hi, everybody. John Marcinkiewicz, person living with HIV/AIDS and vice chair of the Mentorship and Outreach Committee. And I like what everyone says too. I like to be out toward the second half of the day when the sun is still out, but then slowly going down until nighttime. And in between that, I like to have barbecue, like shish kebab stuff. That's my favorite things to do in summer.
Thank you, John. Siobhan?
Hello, Siobhan Cato, Program Director for Zoo for Health and Planning Council member. My favorites, that was the thing, favorite summertime, right? Anything to be outside. So concerts, go to restaurants outside, go to the beach, wherever.
Thank you. Carlton? Carlton? Okay, there you go.
I'm going to stay off camera. I'm going to stay off camera from Sunday because no matter what you see that. I am Carlton Bruce. I am a consumer and I am a board member of the High Council. And I hate the summer, so my favorite thing to do is to be in there.
Carlton, you were a little broken up. I think you were saying that your camera wasn't working. Do you want to try again? There you go.
Can you hear me now?
Yeah, we can hear you.
So we'll stay off camera until Monday. Yeah, I know it's the summer, so sleeping in there is my favorite thing to do.
A little choppy. Okay, wait, it's a little choppy, Carlton. Maybe let me go to. There's two more people. I'll try to come back to you again if you're able to resolve it. It was a little choppy. That's all. Vanessa,
Hi, can you guys hear me?
we can.
Yes.
Okay, medical case manager. My name is Vanessa, medical case manager for the VNA, and I think my favorite thing to do in the summer, besides making memories with my kids, is taking cold showers nonstop.
Sounds great. Actually, Carlton, if it helps, maybe you should type it into the chat. I don't know if you're able to do that. Maybe that would be the easiest thing. And we actually had someone on an iPhone. I don't know who it is. I don't see a face. If you'd like to chime in, person on iPhone.
Looks like
Okay.
you're muted.
If you are having trouble unmuting, it's *6. Or not sure if you're able to put something on the chat, but you can also write it up on the chat. Okay. So I don't know, Carlton, if you wanted to come back or you want to put something in the chat. Okay, I think we're all right. No, I feel like people, okay, no one's coming back. Okay, sorry about that. Little technical difficulties there. All right, thank you so much for all the introductions and the icebreaker. At this point, I'm gonna read our mission and have a moment of silence. The mission of the Planning Council is to establish and implement a comprehensive plan for the organization and delivery of HIV-related services as described in the Ryan White HIV/AIDS Treatment Extension Act of 2009. So now we could have a moment of silence to remember folks that we've lost and folks still living with HIV. Thank you. So as I had mentioned earlier when we first started, we're gonna kind of skip the next few items of our agenda. And we'll pick that up after the presentation. So I would like to introduce Ann Bauchi, and she'll be discussing stigma as structural determinant of health. Ann, take it away.
Yeah, thank you. Appreciate you having me. Let me get my slides up here. So, Roseanne, you may be interested to know that this presentation was inspired in part by the study we did. We implemented the People Living with HIV Stigma Index, so it kind of formed the background to some of the work that's going to be talked about today. So as I mentioned, I'm a professor at Rutgers. I was in the School of Nursing for about 10 years. I've only been in the business school for 2 years. But most of the work that informs this presentation was done while I was in the School of Nursing. And I'll talk a little bit more kind of over the course of the project, the presentation about some of the work I'm doing right now. Just real quickly, the purpose is to identify how health-related stigma creates and perpetuates health disparities for people affected by HIV, meaning all of us, and provide strategies for dispelling that stigma and discrimination. So hopefully after the presentation, participants will be able to define stigma, understand stigma as a structural determinant of health, and identify characteristics of structural level health interventions, understand the bystander effect and how to step up, and think about how to share the training with others. So just a note that the goal of this training is to talk openly about stigma. So conversations can be a bit difficult. Some of the ideas and language could be triggering to some participants. So just keep that in mind and understand that it all comes out of a positive intent. So we're going to start with defining stigma. So Irving Goffman was a sociologist, and he did the first academic work really defining what stigma is. So anything in the academic realm that you look at that talks about stigma will generally start with this book. And so he defines stigma as an attribute that links a person to an undesirable stereotype, leading other people to reduce the bearer from a whole and usual person to a tainted, discounted one. Now, from that definition, there have grown many others. And so one I particularly like is this stigma framework that was developed by Lincoln Felon. I think it really captures how stigma develops and what it's all about. So it starts with labeling. So this is when we identify salient human differences and put some kind of label on them. You can see some labels in this image that's here. Some of them may have a very negative connotation. Some maybe seem neutral, but basically that's the first step, setting groups apart. And then the next step is stereotyping. So you've labeled people as being in a certain group or category, and now you kind of apply stereotypes. So people who are in that group behave a certain way, do certain things, and then you move on to prejudice. So usually some of those stereotypes begin to take on a negative aspect, and then finally that can lead to discrimination. So you're identifying human differences, you're making generalizations about people, they usually take on a negative connotation, and then that can lead to discrimination. And what I really like about this framework is Lincoln Felon talk about how stigma is embedded in systems of power. So it's really people in positions of power who are able to describe those labels in the first place. And we'll talk more about that in a minute. So if you look at the academic literature, there are lots of different types of stigma that you'll see. I like this example given by Grappone. She's a social worker, because I think it's fairly comprehensive. But if you look in the literature, you'll see other things defined. But in this framework, it starts with self-stigma. So this is the type of stigma that happens when a person internalizes negative attitudes. So an example of this is, it's my own fault I have HIV. I did something wrong. I'm a bad person. So it's taking those negative attitudes from other people and internalizing them. Another is perceived stigma, and that's the belief that others have negative beliefs about certain people, people from a certain background. So an example of this is, people think that everyone with HIV is promiscuous. That may or may not be true, but someone who is from a stigmatized group, someone who has HIV may have that perception that that's how people see people with HIV. Label avoidance is when a person chooses, for example, not to seek services to avoid being assigned a stigmatized label. An example of this is, I'm not going to go to that clinic because the staff there think that I'm dirty. So they want to avoid that label of being dirty, and so they decide not to go seek services. Health practitioner stigma takes place anytime a health professional allows stereotypes and prejudice to negatively affect a client's care. And so an example of this is if a clinician says, well, someone who has drug dependency can't be expected to take medication regularly, so I'm not going to bother giving that prescription. So that's taking in those negative stereotypes and turning them against the person and stigmatizing them based on those beliefs. Public stigma occurs when the public endorses negative stereotypes and prejudices, and so then this can lead to discrimination. And an example of this is laws that criminalize HIV transmission are necessary to protect the public. So this belief that applying these kind of negative stereotypes and prejudices are necessary and justifying them for the sake of public good. And then stigma by association occurs whenever the effects of stigma are extended to people linked to a stigmatized group. So an example of this is when I tell people my clients are living with HIV, they think I have it too. Or people who have loved ones, people living with them who have HIV, they are stigmatized because of their connection with that person with HIV. And then finally, structural stigma, which is kind of our focus today, is when institutional policies or other societal structures result in decreased opportunities for people from underserved communities. And an example of this is individuals with pre-existing health conditions are ineligible for health insurance. So it's putting something in place, a rule, a policy in place that has negative effects on certain categories of individuals. And so that's what we mean by structural stigma. We'll talk more about that in a minute. And then intersectional stigma is just the complex and cumulative ways that multiple forms of discrimination can combine, especially for people from multiple different marginalized groups. And so you can kind of think of someone who is living in poverty, someone who identifies as transgender, someone who is from a religious minority, etc. They may be stigmatized for any one of those other aspects of their condition or who they are, in addition to their health. So all those things can interact to create this kind of intersectional stigma. So understanding stigma as a structural determinant of health. So many of you might have heard the phrase social determinants of health. It's been embedded in the healthypeople.gov goals. And so these are the social determinants of health, the conditions in the environments in which people live, play, etc., that affect their health, their functioning, and quality of life outcomes and risks. So, in the past, when someone was overweight, for example, maybe their clinician would say to them, well, you're just not exercising. But we've come to realize that maybe in their neighborhood, they don't have opportunities to be able to go out and walk, or they don't have access to gyms or whatever. We've come to understand that it's not all about the person, but there are situations in which people are living in that prevent them from being as healthy as maybe they otherwise could be. So that's something we all understand these days. But the structural determinants of health, so these are these upstream decisions that perpetuate and promote downstream inequities. So these are things like policies, the economic systems we live in, social hierarchies, including racism. These are all structures that are established in our society that lead to poverty, inequality, and therefore these poverty and inequality then lead to these kind of health disparities and are these social determinants of health. So some example of structural determinants of health are policies that are put in place. So funding decisions, which agencies get funding? What do we prioritize? Do we prioritize military spending, or do we prioritize housing, making sure people have housing? And with respect to housing policies, who's eligible to get assistance with housing and who is considered ineligible? These are policies, these are decisions that someone made, and they could be unmade if someone wanted to. Economic systems and infrastructure, these are things like the supply chain for healthcare. We saw this during COVID. Not everybody had the same access to personal protective equipment. Transportation systems, whether or not you're able to get to healthcare appointments depends heavily on the type of transportation that's available. And then societal values and norms, and this is kind of where stigma comes in. What's considered normal? What's considered abnormal? Who decides that? So that's what we mean by the structural determinants of health. And this is where those systems of power come in. because people who are in positions of power are the ones who get to make the policies, who get to determine how the economic system operates, and who decide what are the values and norms in society. Now, some of you may have seen this before in various other guises, but I think it really highlights really well kind of what we're talking about here. So when you have a system of inequality, people have unequal access to opportunities and resources. The idea of equality just means you're evenly distributing tools and assistance, but it doesn't necessarily give the people who need the help, the help. And then equity is when you're customizing the tools that can address those underlying inequalities. But what we really want is justice. And this is what structural, fixing the structural aspects is all about. You're fixing the underlying system so that everybody has the same access to both the tools and the opportunities. So this is the ideal condition. So what are some of the root causes of stigma? Knowledge, or maybe we should say lack of knowledge. So that lack of knowledge leads to fear, and then fear-based messaging complicates prevention and care messages, and leads to stigma. And then morality, this idea of the karma effect. If good things happen to good people, it implies that bad things must happen to bad people. And it fuels this whole innocence versus guilt continuum, so that people who are sex workers or injecting drugs are seen as more guilty. There's a moralistic judgment against them that fuels that type of stigma, versus children who might become infected through through pregnancy, or through, these days it doesn't happen as much, but through blood transfusions, are seen as more innocent. So that idea of morality and guilt fuels stigma as well. If you want to, you can put in the chat, besides HIV, what are some other things that are stigmatized in our society? Because there are a lot of things, right? Especially when it comes to health, a lot of different health conditions are stigmatized. Maybe you can think of some examples of stigmatizing words or behavior you've seen. Some of the things that often come up in this when I give this talk are mental health, obesity, diabetes. It could be anything, right? Cancer. All of these things have been stigmatized, are stigmatized, depending on the attitudes and values of society. And we're all affected by these things, right? Whether or not we have a health condition that is stigmatized, we have the potential to have those conditions, right? So it's something that affects all of us because it's embedded in our societal system of values. So what are some of the consequences of stigma? I'm sure we can all think of many. Fear of gossip and judgment. Roseanne may remember when we did the people living with HIV stigma index study, we were expecting to find a lot of healthcare-based stigma, and what we found was that gossip was the most common type of stigma that people with HIV identified, and the one that they feared the most. Hiding one's status from others, avoiding health-related other services because they don't want to be identified as someone with HIV, traveling outside of the community to access treatment, non-disclosure of important health information, isolation, and along with that goes lack of psychosocial support, and I'm sure people can think of many others. Weight and abortions have a lot of stigma. Yeah, absolutely. Absolutely. So there are a lot of conditions, and anything can be stigmatized, right? It just needs the right kind of moralistic attitude within society. So suicidal ideation, definitely. And we know that stigma affects everything within the status neutral continuum. So people will avoid getting tested just because they don't want to know. They're afraid of having to face that stigma, so they might avoid getting tested at all. And once they do get tested, they might avoid treatment, whether that means taking PrEP to prevent HIV or taking antiretrovirals to keep their viral load in check. And then we already mentioned lack of disclosure. And then all of that can lead to that sense of isolation. So stigma affects everything within the status neutral continuum. So what do structural interventions look like? Well, there can be policies. Some example of policies are directing funding to local service agencies. So getting the funding to the agencies that can make the greatest impact within the communities that they serve. Expanding political representation. I always tell people, I always say voting is a health issue, because if you don't have the opportunity to vote, someone else is going to make decisions about your health care. And we see this, someone mentioned abortion. We're seeing that, right? Someone's making decisions about what women can or can't do with their bodies. Infrastructure. So designing service systems for those who have the least digital literacy. We saw this big time in COVID, didn't we? Before COVID, not a lot of people paid attention to telehealth. Suddenly COVID hit, and a lot of agencies and clinics had to turn to telehealth, but then a lot of people didn't have access to the services that they needed because they didn't have access to the tools. And establishing service access within local communities. We see this through the mobile vans that go out into the communities to help serve people who otherwise might not be able to get to appointments. So that can be a structural intervention. In terms of societal values and norms, recognizing health as a human right for all, and then creating policies that enforce that value. And then creating a community environment that doesn't tolerate health-related stigma. And that's really what this presentation is about. My idea for it is really to train people with HIV to run this workshop or run these this type of presentation out in communities. So at places of worship, in community-based settings, in clinics, and get everybody thinking about how stigma affects each and every one of us and how that stigma perpetuates ongoing HIV transmission, that it's really a large part of what goes on. I would point out too, another structural intervention, something that I'm working on right now. I got funding from the state to help train primary care practices in routine HIV screening. So over the next year, we're going to be working with 15 primary care practices to get them to start testing people, universal HIV testing, not based on who they think might be at risk, but just testing everybody or making sure that everybody has been tested. And the idea, the hypothesis is if you can get primary care providers to talk about HIV on a day-to-day basis, the same way that they talk about weight management or anything else, then it will start to alleviate that stigma about HIV. It's just another thing that people talk about, and it's not something taboo. In this part, I'm going to kind of just skip through this. Usually when I do this presentation out in the communities, we go through kind of common myths and facts about HIV, but just for, to maintain the time, I'm going to skip this. But the idea is if you're going to take this kind of presentation out into a community-based setting, it's really critical that people, that you address the myths and provide education to people. I was just talking about HIV recently. One of the groups I'm involved with is a Latino serving organization. And somehow the work I'm doing came up in that talk, and I mentioned something about PrEP. And there were two of my colleagues in the call who both had people, family members, die of AIDS who had never heard of PrEP. And so, and these are Latino groups. So Latino African Americans are disproportionately affected by HIV. And if people in those communities are not even aware of prevention efforts that are available, that's why, addressing the myths and facts and providing education is really critical, especially in community groups where people aren't thinking about HIV on a regular basis. And so the idea behind all of this, to take words from Gandhi, is being the change that you want to see in the world. And so this step-up intervention is part of that. So when you see stigma taking place, when you see someone spreading misinformation, or if you see a bullying situation, more like the picture here, there are three sets of factors that usually determine whether or not someone will intervene. One are individual level factors. So do I have the knowledge and skills to intervene in the situation? Do I feel confident enough to do it? And do I feel a sense of social responsibility to actually do or say something? Situational is how severe is the problem? How many other people are around? What's the cost in helping? And finally, the victim. Who is the victim? Do I have an association with the victim? Is there a perceived deservedness of that victim? Or this goes back to that whole sense of morality. Did that person put themselves in that situation so they don't deserve to be helped? And whether or not you think someone will accept help. So we don't have to delay by waiting for an answer, but I'd just like you to think really quickly, which one of these three things you think is most important in determining whether or not someone intervenes in a situation where stigma is happening. So if you said situational, give yourself a gold star. And we'll talk about why. So I don't know how many of you have ever heard of the bystander effect or the Kitty Genovese case in New York City. So this was in the 1950s or 60s. I can't remember which now, but Kitty Genovese was a woman. She lived in an apartment building in New York somewhere, and she was going home one night and she was attacked. And so she was screaming, she was crying out, and her neighbors in the apartment building, some people turned on lights and they opened the windows, and when the perpetrator saw that, they ran away, but then nothing happened. No one came to help Kitty Genovese, so the person came back and ended up killing her. And so that's what really generated this idea of the bystander effect. So it's defined as the social psychological phenomenon in which individuals are less likely to offer help to a victim when other people are present. So the greater the number of bystanders, the less likely it is someone's going to help. So if you're by yourself and you're out of the park and you see someone just drop down on the ground, you're going to go over and help. Like at least 85% of the time, you're going to go over and help that person. As soon as there's one other person there, it goes down to 31%. And the more people there are, the less likely it is that you're going to help. So that's the bystander effect. When other people are there, you're less likely to help. So when other people, when you see stigmatizing words or behavior happening, and there are other people around, you're less likely to do or say something. And why is that? Well, one reason is the diffusion of responsibility. If you're the only one there, either you act or that person, something bad's going to happen to that person. So as soon as there are other people there, you feel less sense of responsibility. So that's one reason. Conformity. Nobody else is doing anything. No one else is saying anything. So maybe I should just keep quiet. Ambiguity. Is it actually a problem? Am I misunderstanding the situation? I remember I was in New York City once and I saw these two guys who were being very physical with each other, and I thought they were about to come to blows, and I was wondering if someone should say anything, and all of a sudden they started laughing, and so they were just a couple friends goofing around, but there was a sense of ambiguity there for a minute. Is it a problem? Is it not? Obedience to authority. So I don't know if any of you've heard of the Milgram experiment in the 1960s. Stanley Milgram was a social psychologist, and he set up this experiment where he was the experimenter and he had a graduate student pretending to be a study subject. And then they recruited the actual study subjects. And what they would tell the actual subject is that, so Stanley Milgram would say, I've got a person behind a wall here, and I'm going to ask them questions. And every time they get a question wrong, you are going to deliver an electric shock. And every time they get another question wrong, you're going to increase the amount of the electric shock. So this person, the person that they're actually studying, thought that the graduate student was the study subject. And so Stanley Milgram would ask a question. The student, as soon as the student would get a question wrong, the person would deliver a shock, and then the student would kind of pretend that they had actually been shocked. And of course, they actually weren't, but this person didn't know that. And so the study would go along, and they would increase the amount of the shock. And sometimes the study subject would say, "Oh, seems like they're they're getting hurt? Do you think we should stop? Because this person, the research assistant would really, you know, like cry out, make a lot of noise as if they're in a lot of pain. But Stanley Milgram would say, no, this is what they signed up for, so you have to proceed. 68% of these study subjects delivered what they believed to be a lethal electric shock just because he said so. So that obedience to authority. And you can think of a situation more recently where there was a police officer kneeling on someone's neck, and there were other police officers standing by, and nobody did anything. Same concept of obedience to authority. So if someone who's in a higher position isn't doing something or is behaving badly, then we may not feel empowered to do anything. So a lot of factors can affect whether or not we feel that we can offer help, maybe because of our age, our own gender identity, our body size, so many other things. And it kind of goes back to that concept of intersectional stigma, that if I feel stigmatized because of something about me, I may not want to risk trying to help. So the idea behind Step Up is to move from passive to active. So the model starts with noticing the event, interpreting it as a problem, assuming personal responsibility, knowing how to help, and then implementing the help, so stepping up. So first, you have to notice the event. You have to notice that there's actually a problem here. Apparently, it's supposed to take 10 seconds for you to identify what's the problem with this picture. I'm going to be the first to admit it took me longer. But the idea is there are watermelons growing on palm trees. So if you don't notice it, it's not a problem, right? So notice it. And then interpret it as a problem. Don't stick your fingers in your ears and pretend like you don't know that something's wrong here. So when you hear someone using stigmatizing words, you have to understand that yes, this is problematic. And then assuming personal responsibility. So another couple great quotes from Dr. King: "The time is always right to do what's right. And the ultimate measure of man is not where he stands in moments of comfort and convenience, but where he stands at times of challenge and controversy." And then knowing how to help, having the right tools for the job. We'll talk about that a little bit more in a minute. And then step up, act to intervene. So this could be direct in the moment. If you hear someone who's saying something that's misinformation or speaking to someone in a way that's not respectful, you may be able to intervene directly in that moment. Sometimes it's good to distract, so just kind of interrupt the situation without directly confronting anyone. And then sometimes it's best to delegate, finding someone who's in a better position to handle the situation. But the idea is to interrupt the situation, either directly distracting or delegate early as possible within the process. So most often trying to be direct intervention. But the important is to make sure that whatever you're doing to interrupt the situation is safe, that it's early, and that it's something that's effective and that's not actually going to make the situation worse. So it really starts by creating a culture of support. And so how do we do that? Talking openly about stigma. Part of the thing about stigma is that it's taboo and people don't want to talk about it. Talking about it might imply that you support it or that you endorse some of these negative beliefs. So if you talk openly about it, people can be more clear about what are the values we're trying to set up in our community. So going back to that idea of structural support, creating that kind of environment within your clinic, within your community, that doesn't tolerate stigmatizing words or behavior. Just choosing supportive language, speaking out to correct myths and stereotypes. So when you hear someone saying something, find a way to correct the situation. Educating yourself, keeping yourself educated, because we can all be educated in the moment, but things can change. We've seen that, we've all seen it, right? And it just kind of goes along with this THINK acronym. Before you think, is it true? Is it helpful? Is it inspiring? Is it even necessary to say it? And most importantly, is it kind? And so part of this is also perspective taking. Just really quickly, think about what do you see first when you look at this picture? Do you see a tree, black here? Or do you see a gorilla and a lioness? And did anybody see the fish down here? Just understanding, this is a really simple example, of course, but just understanding that people can look at the same thing and see something completely different from it. Another aspect is living by value-based decisions. So, you know, we're all about integrity here. By the way, if my wife calls, tell her not in. And run this by the legal department, but run super fast so the ethics department doesn't see it. So having the sense of value, we talked before about health as a human right, dignity as a human right. So understanding those and living by those and making decisions that are based on those common values. And some of you may have seen this before, this idea of different intervention styles. So some people are more dominant, they're direct, they want results right away. Some people are more influential, so people kind of follow them because they're inspiring, they're engaging. You have people who are steady, they are tactful, diplomatic. And then you have people who are more conscientious, they're analytical, they're reserved, they like to kind of sit and sort things out before they intervene. And you may identify with one of these. For example, like I tend to be analytical. I like data. I like to analyze data. I like to think about a situation before I act when possible. But just keeping in mind that even if you identify as one of these kind of predominantly, there are situations where you have to take one of these other intervention styles. So sometimes you have to be direct. Sometimes when there's an emergency, you can't kind of sit down and analyze the data and look to see, okay, how strong is the fire? How extensive is the fire? If there's a fire, you got to get out. You got to be direct, you got to be dominant, and you got to get out. So just thinking about in different situations, which one of these approaches to addressing a situation makes the most sense in that context? And of course, emotions can run high. So the most important thing always is ensuring safety, addressing the emotions first, then later on, try to address the conflict. So when people are angry, just trying to get people separated, get them to calm down. And later on, when people are calm, then you can get at the root of what the conflict was. So helping people save face. So this was all really quick, but when I do this training in person, what I like to do is role plays where we try out in a given situation, we try out those different approaches. What would be a dominant way of addressing this? What would be a conscientious way of addressing this? And so these role plays are based on this concept of the theater of the oppressed, which is something that was developed by Augusto Boal. So what he would do, he was a Brazilian labor rights organizer, I guess. So he would try to train laborers to unionize, to fight for their rights. And so he would use role plays and acting out role plays as a way to help train people. And so what defined his approach is that, you know, there would be a role play going on, but the people who are watching weren't just spectators. He called them spect actors. So what he would do is he would say, okay, here's a situation. People would start to act it out, and then he would pause the action once in a while and he'd say, okay, what do you guys think? What's working well here? What could they do differently? And people would make suggestions. They say, okay, come up here and show us how that would work. And so that's what we do when I do this kind of thing in person. So we set the stage, identify who are the participants, what's the setting, what's happening, and then we have people act it out, and then we discuss it. So I don't know if the whole point of this has been clear, but the idea is that stigma is all about what we accept as societal values and acting in a way that labels and creates negative attitudes towards people based on those values. So everything that exists in our society was created by humans and can be adjusted. It can be changed. So the idea behind this step up is when we see negative behaviors, negative policies, and the idea is to think about policies that are in place that restrict access for people to services and other things that they need. What could be changed? What could you do to step up and change the situation? So the idea is, like I said before, what I'd like to see is that these ideas get spread out to the broader community, because it's fine for those of us who are working in the space of HIV to be talking about this, but if it doesn't get out to the broader society, to our church leaders, to our political leaders, to the broader community, it's not going to change. So the idea is to recruit people living with HIV to lead this kind of training, conduct the trainings in community settings, as I mentioned before, maybe clinics, places of worship, community centers. I'm sure you could think of others. And we'll look to see, is it really leading to changes in people's attitudes? And how can we share the lessons learned with other members of our communities? So I always like to pause and just give people a time for reflection, to kind of think about, was there anything that we talked about today, or that I talked about, since I've been doing all the talking? Was there anything that was kind of new to you, something you hadn't thought about before? Maybe ways that you could think about changing the way things are in your broader community, not just in your clinics, like I said, but in your broader community, ways that you could help to change those social norms about what is stigmatized. And happy to answer any questions at this time.
Hello?
Yeah.
Go ahead. Hello? Hi. My name's Kathy. I'm sorry, I couldn't log on to the Zoom. I got, my connection was bad, but I was listening via phone on Zoom. I think one of the things I've always been told, a lot of people don't see things the same way that I do, but I try to look at it as just treating individuals equal. But I know that's a stigma with certain individuals, especially depending on the environment where you're in or work in, because what I've noticed automatically, a lot of people assume for the Hispanics that they don't speak English or they don't understand. And I think it's just out of a common courtesy, it should be asked upon what they feel comfortable speaking in, so that they can open up and speak on their behalf about situations such as this, because they do have a lot of feedback. But I've noticed a lot of the stigmas that Hispanics have built, from what I've seen, is their opinion may not necessarily matter or count.
Right. Yeah, I've seen that too. And so I'm a sociologist. I'm also a family nurse practitioner, and I do speak Spanish fluently. So one of the things that makes me kind of angry is when I see healthcare providers who kind of jokingly say things like, "Oh yeah, I get by with my broken Spanish," as if that's acceptable, right? That you're not speaking to someone in a language that they can understand, you as a healthcare provider. So you're not understanding them, they're not understanding you. So what kind of quality of care can you really be providing? And that's bad enough, right? But I often hear people kind of laughing about it in a way, kind of like, "Oh yeah, me and my broken Spanish." And I think it's kind of the same thing that you're talking about. It's that idea that some people are second-class citizens, some people are not entitled to the same level of care as others. And that's the type of thing that fuels stigma and discrimination in our society. That question of deservedness. Who deserves what in our society? Blaming the victim, all these things that we've seen and talked about.
Thank you, Anne, for that wonderful presentation. Does anybody else have any questions?
All right. Well, thanks, everybody. Got another meeting I've got to go off to, so it's nice
Oh.
seeing you again, Roseanne.
Thank you so much, Anne. It was a pleasure
Thank
to have
you.
you. Thank
Take
you so
care.
much.
Bye, Ann. Good to see you. Take care.
All right, everyone. We're gonna go right back to the agenda and do roll call. So I'm gonna hand it to Jen so she can do the roll call.
Hi, everyone. If you could just come off mute for me when I do a roll call. I'll start at the top. B.
Here.
Carlton. Carlton, I see you on. If you're, oh, there you are. Just,
He's muted, Jen. He
yeah,
was muted.
I see you here. You're good. I know you might be having some difficulty. Siobhan. Siobhan's still on. Siobhan, if you hear us, just jump on and say here when you get a chance, please. Jay is not here. I've not seen Jay jump on, right? No, okay. John,
Here.
Jose, still with us. There you are. I see you.
Here.
Kareem,
Here.
Kathleen,
Here.
I see you. Kelly, Kelly back with us.
I'm here.
I see you. Okay. Lara,
Here.
thank you. Manu,
Here.
thank you. Roseanne,
Here.
I know Cheryl is absent today. Tanya,
Here.
thank you. And then Vanessa.
Here.
Thank you all. We have a quorum. We are good to go.
Thank you, Jen. Okay, so let's have the minutes. We need to review and approve the minutes. Jen, are you gonna present them or they were me? Okay, thank you. Just wanted to make sure before. Hopefully you guys had a chance to review it already. Okay, when you are ready, please give me a motion for the minutes.
I'll make a motion.
I'll second it.
Thank you, Roseanne and Kelly. For all those in favor, say aye. Or raise your hand.
Aye. Aye.
Aye.
For all those opposing. Any abstentions? The motion carries. Thank you all. So the next agenda item is the approval of agenda, but we kind of already changed the agenda a little bit. So are there any items that need to be added or changed? If not, may I have a motion for the agenda?
Motion to approve the agenda.
Thank you, Jose. Can I have a second, please?
I'll second it.
Carlton? I think that was no, Kareem,
That's
sorry. That was
Kareem.
So all in favor?
Aye.
Aye.
And those who are opposing? And any abstentions? The motion carries. Thank you. We have approved minutes and agenda. I'm going to hand it to Lucy for the administrative agent report. Lucy?
Hi, very quickly. So we, today is what, May 7th, and we still do not know when we're going to get the remainder of our funding for this program year. I did get an email, Monday, I believe it was, Monday, yeah, this past Monday, that from HRSA that all Part A grantees should expect to receive our awards sometime in May. That could mean tomorrow, that could mean the end of the month. We're just kind of like waiting and wait, kind of have to wait and see. I did reach out to our project officer is out for the next month or so, but I did reach out to his boss to see if she had any additional information to provide, and she said she did not. So right now we're just waiting. I'm hoping that we get it so that I can continue, programs for, or let providers know what their funding will be for the remainder of the year. And then the other thing I've been talking about for some time is we finally got our new food program off. We finally got it started. We've had a couple of hiccups here and there, but we've been able to get gift cards out to consumers who were referred for both March and April. They were sent out at the same time. And now we're working on getting referrals for May so that we can get those gift cards to the consumers. Based on what we have gotten for the referrals, instead of doing what we're doing gift cards for 2 stores based on the address, the client's address, whichever store is closest to their address. So it's either an Aldi or Lidl, however, I know everybody says it different, but that store, either of those 2 stores, they're getting the gift cards for. We did talk about the need to increase the amount of money that was going into per client. So we have to serve less clients because it's costing us more to provide the service. But I hope to have we'll get through May, and by June or July give you all an update as to where we are. But I think May should be a lot smoother. We've worked out some kinks in referrals and what needs to be done, what the process is, but I think we're good to go now. So yeah, I'll give you all a more concrete update on that in July. And that's all I have.
Lucy, this is Steve. I have a quick question. Wasn't Trader Joe's originally on that list? Is it down to 2 providers now for food?
Yep, 2.
Okay.
Because there was only one person who would have gotten Trader Joe's, so I wasn't going to make a 1 gift card purchase at 1 store for 1 person.
Oh,
Yeah.
that makes sense. Thank you.
Thank you, Lucy.
Somebody
John asked really quick in
Oh,
the chat, sorry. John just put in the chat, what does one need to do for a referral?
Well, like our other programs, they have to be eligible for the program, and if they are eligible for the program, their case manager will refer them for services. So same requirements. Nothing has changed as far as the requirements. It's just that we cannot serve as many people because it's costing us more to execute the program.
Any other questions for Lucy? I don't see any. Okay, thank you, Lucy. We do not have any old business, so we're going to go right into new business. So for the last couple months, we've been talking about the EFA service standard. We are presenting it back up for vote. I believe there's a slides we want to share with you. So Jenna's going to share that, and then we'll go over it. Okay. So really good thing I printed this out. Those are tiny. Okay. 2020. I'm sorry, I'm just making sure I have the right slide in front of me. Okay, so the first part is the change that is, oh, okay. Thank you, Jen. All right, thank you. Okay, so the first part right here, what it used to say is each client will be eligible for up to $750 per year for EFA. And then a year is defined as 365. The change that has been made is that each client will be eligible for emergency financial assistance every 18 months. And the intent to expand the time frame, the intent was to expand the time frame in which clients are eligible to open up the service to more people. The second slide. So as you can already see, the language has been simplified. So just to make things less confusing, let me just go over the suggested changes. So right now, what it would say is each client will be eligible for up to $750 for emergency financial assistance. So that is referring to utilities assistance. The second bullet point, which refers to rental, each client will be eligible for a maximum amount equal to 2 months' rent at fair market value based upon lease amount. So simplified language. This is what we have from the committee, and it went through executive. So can I have a motion? If we have a motion, then we can have discussion. I believe that's the way it goes.
I make a motion to approve.
Oh, thank you, Lara. Is there?
Second.
Thank you, Jose. I think this is a roll call vote. And if I'm not mistaken, you have to be mindful of your conflict of interest, correct? So if you are an agency that is, but could be funded for this or are funded for this particular service, please abstain. Ready for the roll call vote?
All right. So with that motion, accepting the EFA verbiage as is, starting with B.
Yes.
Carlton. I don't think we can hear you. If you want to, you could throw it in the chat and I can read it, if that makes it easier for you. For some reason, I see you're off mute, but I still can't hear you for some reason. I'm just gonna keep going, then I'll come back to that one. Siobhan,
I'm abstained.
Jay is not here. John,
Yes.
Jose,
Yes.
Kareem,
Yes.
Kathleen,
Yes.
Kelly,
Abstained.
Lara,
Yes.
Manu, we skip you. Roseanne,
Yes.
Cheryl's absent. Tanya,
Yes.
and Vanessa.
Yes.
And then Carlton, to answer your question, yep, because we presented it here, we talked about it here, you can absolutely vote on it. So if you're good with a yes, I see, we're gonna count that as a yes. All right, we have 1, 2, 3.
Did you get Kathleen's vote?
Yep, I did. So sorry, I gotta count again. 1, 2. We have 10 yeses, 1, 2 abstains. That's a pass, guys.
Thank you, guys.
On EFA, thank you.
5 months later, but we're good. We're good. Okay. So what we have upcoming next is the committee reports. So I'm just going to go down the list. The first one we have is Executive Committee, Tanya. And Tanya, oh, I'm sorry, go ahead. Didn't mean to interrupt you. Go ahead, Tanya.
I'm pulling it up now. What was you gonna say, Manu?
So I thought your committee was up next. So I was going to say you could do both committees, but it's not. So sorry, just if you could do executive only, please.
I just had the executive committee report. Jeez.
If you want, we can come back to you. You can do executive and mentorship together. Would that work for you?
You have the mentorship one up.
I could do
John
mentorship
has
if
a
you want me.
question.
Yes.
Yeah, I said I could do mentorship if you want me to, so you don't have to do 2, Tanya. It's up to you.
No, oh, I pulled up the executive.
Thank you. Okay.
So the executive committee met. Where did it go? Executive. It's great. Mentorship and outreach. Quiz. So the executive committee met on the 17th. The committee members met. The quiz meeting, the membership and outreach committee met prior to the executive committee, no report. The quiz committee met. Jan reported they completed the emergency, the EFA, And they would also work on the outreach service standards and sharing oral and service standards, which will be reviewed next month. The membership and outreach committee met, and Jim pulled up the work plan. And the ideas that were talked about were about videos being put inside the it's basically the same thing as the mentorship committee. But the mentorship committee met, we talked about posting videos in waiting rooms with the providers, and also talk about doing an outline for recruitment. The mentorship committee also talked about materials needed to put inside the agencies. Jay, you want to talk about John, you want to talk about anything else that was reported in the mentorship? Because if I read the executive committee, it's still also the same thing in the membership and outreach. So I might as well do both of them at the same time. So go ahead, John.
Can you everybody hear me okay? Okay. So let's see, what else did we do? We did a lot in our meeting and went over a lot of things.
World AIDS Day.
Yeah, which I still haven't secured the church yet, but hopefully that'll be done by the next time we all meet. And then I just saw information today. This isn't really from that, but Roseanne sent a message. I think Roseanne sent it about one of our former planning council members wanting to perform or something at World AIDS Day. So I think that's great if that comes to fruition. Oh, or maybe not. Anyway, well, forget I said that. We also we were asked to do a presentation on recruitment and outreach for the case managers. Tanya and I are going to be doing that tomorrow, just on the dire emergency of us getting new members for our planning council. It's been talked about for a long time, and we keep losing sight of that, I think, and it's getting down to the wire that if we don't get new members, we're in a lot of trouble. And we could lose our funding and everything. So we're going to try and, brainstorm with the case managers and just like, do a little presentation about what we think as consumers and also our past of working in the field, ways that we did that were successful in recruiting people. And then we also, we discussed a few more different ways of doing the live flyer program, and also our TGA theme implementation for the mentorship brochure poster for planning council members, which is I think that's going to be talked about at case manager meeting too. Maybe shut me up if I'm wrong, Jen, but about getting the flyers or the cards or whatever that are available for people to have at their agencies, but they have to pick them up. That was talked about. So if I didn't say that right, somebody correct me. And okay. I don't remember what else. I can't think of what else we did. There's a lot of, as you can see, if you were able to see the minutes for our meeting, it's a lot, because we do a lot in that meeting, and we run right up till 8 o'clock, if not longer. So, anyone wants to come by, come on. I think our next one is next Wednesday at 6 p.m. Okay, back to you, Tanya. Thank you.
Okay. Also, we talked about ADDP issues. An announcement was from Jen regarding the August Ryan White conference, and everyone agreed on Roseanne to make sure of the announcement of the next planning council. And we also talked about the transgender health fair on the 22nd. And that's basically it.
Thank you, Tanya, and thank you, John. Okay, so we're going to go to membership and bylaws. Roseanne?
Okay, everybody, we also met on April 17th. And we're in the process of, going through the bylaws, just going over some language. And Tanya asked if new members receive the bylaws. And they are given out twice a year at minimum, once the onboarding and once during the annual orientation. And I believe once they're updated, they'll be on the Planning Council website. We also, again, this kind of is a bridge between mentorship and outreach. We talked about recruitment update. We did send an application for new membership to George Higgins, but I don't know now with Jose being back. And as far as the mentorship program, they discuss who would be responsible for mentoring and intervening if a member brings on more than one person. So whoever the recruiter is, and we're all recruiters, so that recruiter may not interview the person they recruit. So that may be given to another person. Again, reinforcing about, how low we are with members. And regarding the National Ryan White Conference, it falls during an executive committee meeting time. So we are going to move our meeting to the 28th. And that's for executive committee. And Planning Council meeting, so we have June and July will be, and August will be the same, correct? First Tuesday of the month. Thank you. I know Terry's putting some things in the chat, but I can't see it.
Look at the bridge.
Okay.
She was just mentioning the date changes we're talking about are for for August.
For August, yes, that's
yeah.
for August. Did I say April? Okay. So
I'm
August.
not sure, but yeah, just to clarify, yeah.
So the meeting, the executive committee meeting and committee meetings are changed in August because of the National Ryan White Conference. Thank you.
Thank you, Roseanne. Okay, so we have the Quality Improvement and Strategic Planning Committee, and unfortunately I was not there at the last meeting, so Lara's gonna help me out with the update.
I didn't know.
Sorry,
I was
Lara.
gonna-
That was the worst.
I was like, is she? Because I thought it was me. She just
I
threw
was
you right
like, I'm like, oh, okay. I don't have any notes, but hey,
Sorry, Lara. Lara, your face was right in front of me. In my mind, I was thinking Jen, and I called Lara. So that was not intentional.
I was like, oh, great. I didn't know she was.
that's literally like straight up teacher mode. Like, okay, Lara didn't do her homework, and I can tell, and I'm calling her out in front of the class. I was
sorry,
there,
I meant
but
to say Jen.
I
When
go
your
ahead.
face was right there.
You don't have to be on the spot. I wrote notes, so.
Thank you. I'm sorry. I meant to say Jen will provide the update.
So
Thanks,
for
Jen.
quiz, yep, I got it. I wrote notes, so we're good. So we did the EFA verbiage at quiz. Obviously, we know that it's already been done. We got that finalized. It went to executive and then here. And then we worked on the outreach service standards because we realized that although we are funding outreach, we did not have a service standard in place for some time now. So we actually took an old outreach service standard and just sat and modified it and updated that. So now we have a current outreach service standard in place, and that took the majority of a good portion of the meeting. And Vanessa was so willing to join us to help us out there, which was great. We decided our next 3 service standards to review were going to be medical case management, health insurance cost sharing, and then oral health services. And then the last thing we did, or the first thing we did in the meeting, was we had our fiscal report from Joe. And he let us know that they were still working on fiscal year 2023. So he gave us some updates on that, but the main point of what he was talking to us about was the fact that there wasn't anything really to report on this year yet. And we would see, he comes to the meeting every 2 months. So we will see in June a better, start to see an idea of how we're doing this fiscal year. So we'll have some better updates come July for you all, what 2024 was looking like so far. And that was it. And then Terry did say something, because I think I said something wrong. technically it's not in place until the planning council approves the service standard, so. It's drafted, I'll say that. We drafted a service standard. There we go. And that's it. And we meet, should say this, because I'm gonna keep forgetting. We changed the date of this month's meeting because of another conflict. So we are meeting, Chris was meeting on the 14th next week. Instead of
And
the
thank
3rd.
you. Thank you so much to the committee members who are accommodating me. I have my site visit on May 21st. So that's why I couldn't make it. Thank you again. All right, those are all the committee reports. So it's time for public forum. I feel like there was something in the chat that was okay. Anything for the public forum?
Yes, Manu, I would like to just remind everyone that on June the 5th, we will be having our HIV Long-Term Survivors Day event, and I hope to see you all there. And if anyone wants to participate in a big way, please reach out to me and come, and let's see what we can do to make it possible.
Thank you, Kelly. Roseanne, did you want to are you raising your hand?
I have to talk to Kelly, so thank you.
Oh, okay. Anybody else on the public forum? Okay. Oh, sorry, Kathleen. I see you now. I see you, Kathleen.
I don't know how to get it to everyone to see it, but on America's Got Talent, there was a skit about stigma with some transgender and some other issues, and it was very inspiring. But I sent it to Terry, but I don't know how to bring it up here.
You said it was on SNL?
No.
No,
She said
America's Got Talent.
Yeah,
Oh, sorry.
she sent me the video, and I had suggested that we look at it. If you're ready, I can pull it up now. Because it's fitting, it aligns with the presentation we had earlier for sure. Yeah,
You want to play it now?
Yeah, if you're cool with it,
Okay.
I'll do that.
Yeah,
Everyone,
I don't
it's
think
like
you
a
have anything else.
3-minute
Yeah.
video. The only thing I wanted to add to Kelly's announcement is that we're pairing the Story Slam with the Long-Term Survivors Day. So we're really excited because a lot of people from our TGA are participating and they're receiving training. And I think it would be really great to support them in that effort as well. Now, I know everyone probably goes, but I just wanted to add that extra plug. So, okay, are you ready? Okay. Let me share my screen. Okay. I don't hear anything. You guys hear anything? Oh, here we go. Oops, sorry.
What?
We still can't hear anything.
Okay, wait. I don't know what just happened.
What night was it on?
Oh, that's not
I
it.
saw it on Facebook or TikTok, one of those. I saw it.
Is a threat.
Say I can't. I will.
No, your mom don't get it, and your dad don't get it, Uncle John don't get it. And you can't tell grandma 'cause her heart can't take it and she might not make it.
I'm Declan, and labels don't define me. I push the gender boundaries, but don't allow discrimination to change who I am. People stare and say things. They try to label me. They say I can't be who I am. I will.
They say don't dare, don't you even go there. Cutting off your long hair, you do as you're told. Till you wake up, go put on your makeup. This is just a phase you're gonna outgrow. There's something wrong in the village, in the village. Oh, they stare in the village, in the village. Oh, there's nothing wrong with you. It's true, it's true. There's something wrong with the village, with the village. There's something wrong with the village.
I'm Steph. I'm Libby. And we are in love. Since we came out, we constantly have eyes on us. For something as simple as holding hands walking down the street. But as a male and female can kiss in public, and no one would look twice. They don't want us to show our love. We will.
There's nothing wrong with you. It's true, it's true. There's something wrong with the village, with the village. Something wrong with the village.
I'm Junior. Growing up, I was bullied for my love of dance. Dancing makes me feel free and allows me to act out my feelings in a safe place. Bullies ruined this. I was beaten up and called names, all because a boy loved to dance.
I'm Kira. Society has conditioned me to believe that I will never be good enough because of my size, that I will be unsuccessful if I don't change my shape. People say I'll never make it. I will.
There's something wrong in the village, in the village. Oh, they stare in the village, in the village. Oh, there's nothing wrong with you. It's true, it's true. There's something wrong with the village, with the village. Something wrong with the village.
Our abilities aren't hindered because of our differences. Our talents aren't any less because we are unique. Our worth isn't defined by our diversity. It is not our differences that divide us. It is our inability to recognise, accept, embrace and celebrate those differences.
I'd never judge somebody on the way they wear their body, but I pull myself to pieces. I don't know why I do. If I could only learn to see myself how other people do, I'd say I'm not my thoughts. This is my house and these are my rules. When I stand in my reflection,
Wasn't expecting that.
say I'm not my thoughts. This is my house and these are my rules.
You can be anything you want and anyone you want to be in life. The message is loud and clear. The execution, artistically, your choreography was superb. It really is a fantastic performance at every level. I had goosebumps, that's all I can say.
Well, it was such a beautiful...
The audience want a goal, but there aren't any goals left.
Bruno press it anyway. Doesn't care.
I've already done it twice. I can't anymore.
For me, it was such a beautiful, passionate piece. The message was so strong. Everything that you stand for, all of your personalities, the love that you have for each other, all the different characters involved in this group, all of that made this such an amazing and special piece. It was beautiful.
I thought that actually was astonishing. The way that you got your message across, it was so strong. It was an audition I'll never forget. What you've done it your way. And look, we don't have any golden buzzers left.
They'd be nailed on for a golden buzzer if we had any left.
But sometimes I feel you should just break the rules.
Anymore.
That was awesome. Thank you. Anybody want to say anything? Comments, thoughts?
You didn't have crying on my bingo card today.
Same.
That's how I feel too. Yeah.
Beautiful, Kathleen. Thank you so much. That's really a statement beyond beyond words. The way the world should be.
Yeah, the songs they picked to go with it, everything had meaning.
Yeah.
Very inspirational. Very inspirational. So I can say,
Also,
moving.
yeah, also a great way to kind of sum up the presentation and what we, our meeting today. Well, thank you for sharing that. And well, we got one more person, and this time I'm going to get it right. Lara, you're up.
How do I follow
with
that?
A great Part B update.
Kathleen, thank you for sharing that. And I feel like the universe just kind of works, right? Like if you shared this earlier with Terry, like how did you know, that it would all just kind of come together in that beautiful way? And sometimes you just I don't know. I'm kind of left speechless, and it just makes us all think. And even I don't know if you can see in the chat of what everybody was saying. So take a look, but Carlton with the how the song just played off of it takes a village, and it's so true. Anyway, I guess back to business. Sorry guys. Womp womp. Very brief on my part. I put it in the chat. Hopefully it'll post. Okay. We're moving to a new format with our Part B over at the DHSTS. We're having quarterly meetings. So that was the save the date for the 17th. We don't have a registration yet. I actually just asked about it today. It's coming, I was told. So it's coming. And when it does, I'll be sure to share it with Jen to disseminate that. So we're all Part A. You're welcome to join. But I know our focus, let me take a peek because that's really tiny. I'm a part of the planning committee, but I know every quarter we're going to be focusing on a particular area of kind of like what we do here, I think. But it's really going to be housing focused this quarter. So bring your housing questions, thoughts, inquiries. I know we're going to have, there's going to be a presentation, discussions around careware, all of that fun stuff. So that's what we'll be doing on the 17th. So registration to come, and I'll be sure that that'll be sent out. So that's all I have for Part B.
Thank you, Lara.
Thank
All
you.
right. agency and community announcements. We've had one already. So is there anybody else with any sort of announcement?
I
Yes,
have
Jen?
some. Yep, I have a couple. Now I wish I went earlier so we could have ended on that high note. I regret my decision. But I have a couple things to just go over. Again, I just wanted to reiterate the August changes. I will send out an email with all of those changes for the date. It's that 1 week, and it's a couple meetings that will get pushed around. So I will send that out to everybody so you have it in writing. And I will also update the calendar invite so it reflects there also. Besides that, I did create a Google form for like presentation surveys. So everyone will get that. I'm going to send that out probably tomorrow at some point for everyone. Please, please, please go into it. Please click into it. Please fill it out for me. It will just help me, but then also our mentorship and outreach committee who plans our presentations. Just understand better how we liked the presentation. It's a couple quick questions. Again, it's just a Google form, and you do not have to have a Gmail to answer it. So if it prompts you to say that, just use whatever your regular email is that we're sending it to, and it will work. If it's not working and you'd like to fill it out, and I'm begging you all to do it, please, just reach out to me. And again, you do not need a Gmail to fill it out. I know sometimes it's weird and it says that, but it works even if you I use my Yahoo one when I practice it. So, and then my last thing that I wanted to talk about that was touched on briefly was mentorship and outreach has been going over some recruitment situation, like ideas with the live flyer program and stuff like that. But one of the themes that we continuously are talking about is how it is not that committee's sole responsibility to recruit. And in that conversation, one of the consumers brought up like what materials, like who is recruiting with agencies that are sitting here with us today? Like what materials are you giving out? How are you engaging clients? And it was brought to our attention that there is a lot of people without materials. So to solve that big problem, the pamphlet has been emailed around a bunch, and we are going to update a part of that, and I can email it again. But to solve that problem, I'm going to be sending out an email asking every provider to meet with me. I will meet you halfway. I will come there on a certain day if needed and provide materials. That being said, we're also going to come up with some type of accountability method to make sure that when we're providing the materials, if I'm bringing the materials, you have the materials, you're actually handing out the materials. We want to know who you're handing them out to, what you're doing with them, so that we see that there's active recruitment going on in that way and that we're actually using them and that you're requesting more from me because you are using them. So this is a working thing we're trying to figure out how to do, but expect an email from me very soon with a timeline of picking up the materials or meeting me to get the materials to hand out to people. And I'm talking paper in hand, physical materials that we're handing out. So I just wanted to put that out there. And that's all. Thank you.
Thank you, Jen. Any other announcements from agencies? Looks like it's a no. Kathleen, are you seeing all the chat comments about you? Okay, good, because I was going to sum it up. Like, you're awesome. That's what that's what it all said. Okay, with that.
Thank you.
Oh, sorry, somebody said something? Nope, I'm hearing things.
I was just saying thank you, everyone, for your comments.
Thank you, Kathleen. Okay, thank you. With that, can I get a motion for adjournment? You get 20 minutes to go enjoy that weather. I don't know if it's so warm
one
out.
question. Can Roseanne, are we meeting for Part D tomorrow?
No, there's no Part D meeting tomorrow. Courtney sent out an email. They had to cancel the meeting. They had a conflict, so there's no Part D meeting second Wednesday of the month. But we'll see you at the case managers meeting then, you and John at 2:00.
Yes.
Excellent.
At 3:40 is when they're joining the meeting.
3:40, okay.
3:40.
3:40 to be exact.
But tell me 2:00 so I get there on time.
All right, now can I have a motion to adjourn?
I'll make a motion to adjourn.
Thank you, John. It's like, okay, I don't know who the second was. Tanya. I think I heard Tanya.
Vanessa.
Oh, it's Vanessa. Okay, okay. Can tell. Okay, and Carlton. Okay.
Bye, everybody.
Thank you all.
Nice to see everyone.
Have a good
Bye-bye.
night.
Good night.
Bye-bye.
Meeting is ending at 7:43. Jen, you got the
Yes,
meeting
Kelly,
at
I'm gonna, I'll
7:42?
give you a call.
Okay,
Thank
7:40.
you.
Yep, for Sabrina, it was 7:43. Thank you.
John, did you want to?
Yes.
Okay. You did want to stay
Hi.
on. Hi.
Oh, just for a minute. Hi, hi everybody. Jen, I'm still working on my stupid sentences for the presentation. Tanya's calling me right now. Tanya, hold on
Oh,
1 second.
okay.
It's her.
You still
I
have
just wanted
within
to
recording.
check.